अस्सलाम वालेकुम। जैसा कि आप लोग जानते हैं कि आज हमारा ऑक्लूजन की लेक्चर सीरीज़ का लास्ट टॉपिक है, इफेक्ट्स ऑफ ऑक्लूजन फ्रॉम अ ट्रॉमा। तो डॉक्टर नगमान ज़ुबैरी इंशाल्लाह आज लेक्चर देंगे। मैं सर को वेलकम करूँगा। अस्सलाम वालेकुम सर, हाउ आर यू?
Uh, I'm good, Alhamdulillah. How are you?
सर आई एम ऑल्सो फाइन। सर आप कंटिन्यू कर सकते हैं।
Okay. So, as you know that we are discussing occlusion for the last couple of weeks, and I told you that today we will discuss that what happens if this occlusion is not in an ideal condition and it starts causing trauma to the tooth as well as the supporting structures. So, what would be the effects on the tooth itself and these supporting structures? So, let's start with it. And as I told you that it is a very vast topic. So, I was just giving you a brief know-how about the occlusion. And if you like, you want it, we can go again like after a couple of different lectures again in future, and then we can again go back to occlusion and we can discuss more like occlusion in more detail. So it depends upon the requirements of the audience. So let's start with the today's lecture. And first of all, we have to see what kind of occlusal forces are there. Normal forces are within the physiological limit, which are being dissipated in the process of chewing or mastication, during swallowing, even at times when you just close your teeth for a very short period of time and then you come back to the rest position. So these physiological positions, like forces, are being dissipated to the teeth. They are very small and they rarely exceed 5 Newton. These forces, they provide positive stimulus to maintain the periodontium and the alveolar bone in a healthy, I'm talking about healthy, and functional condition. If you extract a tooth, then these forces won't be there and will lead to disuse, atrophy of periodontium. At times, we bring the tooth out of occlusion temporarily in case of some excessive forces are there, which could be because of any reason. But at times, we bring the tooth temporarily out of occlusion by selective grinding, and then we can go for recusping or crowning of the tooth and bring it back to the normal functioning status. Normal functioning status where physiological forces are present from the antagonists, it is very important for the health of supporting structure. Impact forces, they are mainly high, but they are of short duration. The periodontium can sustain high forces during a short period. However, forces which exceed the viscoelastic buffer capacities of the periodontal ligament, they will result in fracture of the tooth or at times even the supporting bone. Continuous forces. These are very low forces, just like the orthodontic forces. But when they are continuously applied in one direction, they may displace the tooth as well as they will remodel the alveolar bone. And tooth is going to acquire a new position. Jiggling forces, these are the intermittent forces in two different directions because of premature contact, like some newly placed crown, filling, or maybe some prosthesis, etc., etc. That will result in the widening of the alveolus and in increased mobility of the tooth instantaneously. When we look at the normal occlusion, class 1 molar relationship, class 1 canine relationship, class 1 incisal relationship with appropriate overjet and overbite. Upper teeth overlapping the lower teeth at least like 33% or so. When this person is having a normal bite, normal occlusion, canine guided, it is called mutually protected occlusion. Mutually protected occlusion means when the person is in centric occlusion, so whole burden is on the posterior dentition and all the forces are being directed along the long axis of the posterior teeth. Whereas anterior teeth, either they are in very slight contact with each other, or at times they are even separated. They are not in contact. When a person is that same person is going to bring the teeth in an edge to edge incisal relationship, then they will be having only anterior guidance and posterior teeth are disoccluded. So posterior teeth, they are not coming in contact, no any premature contact, no any deleterious effect during this protrusion, and anterior teeth, they will be supporting the posterior dentition in a protrusion. So this kind of mechanism is known as mutually protected occlusion. It is present in canine guidance. So over here we can see a very nice, beautiful, normal occlusion. The person, when goes in laterotrusive, they have a canine guidance or cuspid rise. When they start moving and shifting it towards the other side, it is not that person will be just chewing on one side. It is a complete cycle. The working side will become balancing side. As the chewing cycle, it will be continued. So over here now the shift over is occurring. Anterior guidance, then the anterior shift over, and we are converting the previously positioned as the balancing side, it will be now working side. The previous working side, it is going to be the balancing side now. And now this side has become the working side. Rest of the dentition is out of occlusion. The other side, which was previously a working side, it has become balancing side, and all the teeth over there, they will be out of occlusion, and then the cycle will continue like this. Another form of occlusion, as I have told you, as I have mentioned, is the group function. But at times, this group function in natural dentition, it has some effects on the teeth. There would be chances of trauma, may lead to non-carious cervical lesions, which we call abfractions. It's a new term which was introduced in 1991, abfraction. We are going to have a separate session on non-carious cervical lesions and how to manage those, inshallah, in future. So I'm not going into the detail, but keep in mind one of these, like there are various types of non-carious cervical lesions, and one of those, they are abfractions, and they are caused by trauma from occlusion. So once if we find out that the trauma from occlusion is being occurred even in the group function, we can convert it into canine guidance. And how we can do it? We can increase the size of the canines, and then we will go like just by adding composite over here, adding composite over here, there will be a separation now. So on the working side, there won't be any interference, there won't be any load on the posterior teeth, and you can save it. But before changing the pattern of occlusion or scheme of occlusion, it is always advisable to spend some good time in diagnosing the problem. If you are not spending the time and you are just going quickly, like in 5 minutes you decided, okay, the patient has group function or canine guidance, and I'm going to switch over to the other scheme, that is not going to work. You will change the whole scheme, which could be deleterious in future for that particular person. Nature has designed our teeth in such a way that all the forces which are being dissipated on the coronal section, on the occlusal section, it is being directed along the long axis as a resultant vector. I have already mentioned that if it is in physiologic status or within the physiological condition, that is going to helpful for the health of periodontium and the supporting bone. If it is going to be off axial forces or the amount of force is going to increase, then what is going to happen? The tooth cannot bear the burden and the supporting structures, they start getting affected. Just imagine a post or a tent peg in the ground. If it is like this, without like, I'm not talking about that we are tapping it, just the post is there in the ground, you want to pull it, you cannot do it. In order to make it loose and pull it, you have to firstly give some off axial forces, and that is going to shake it up, make it wiggly, and once it will be wiggly, then easily you can remove it. Same thing happen to your teeth. When they are in socket, the bone is healthy, periodontium is healthy, the tooth is stable, and it will be just like a tent peg or just like a post in the ground. Once the off axial forces they start hitting it, and the direction of the forces is going to be changed, then the tooth is going to become wiggly. Why? The reason is now the periodontium, it is going to accommodate those forces. And in order to accommodate those forces, the periodontium, its structure is going to be changed. I will explain to you how it happens, just giving you an example from the daily life. The tooth will become very wiggly, will become mobile, and maybe in future it is going to be lost if we are not going to tackle the situation at a very early stage. Trauma from occlusion is the term which we use when occlusal forces they become traumatic and they start affecting the tooth as well as the supporting structure. Occlusal force is a critical factor affecting the condition and structure of the periodontium. In fact, the periodontal ligament and alveolar bone require mechanical stimulation from occlusal forces in order to remain structurally sound. I have already explained that to you. When function is insufficient, these tissues undergo atrophy. I have already mentioned that we have disuse atrophy, and when occlusal forces they exceed the physiologic adaptive capacity of the tissues, then supporting structures they are damaged. Such damage is called trauma from occlusion. Other terms which are being used for trauma from occlusion over the period of time is traumatizing occlusion, occlusal trauma, traumatogenic occlusion, periodontal traumatism, and occlusal overload. We also use this term overload even in our implant dentistry. So what happens? As I told you that our tooth is designed by the nature in such a way that it is going to have the forces which will be dissipated or which will be directed along the long axis of the tooth. But whenever we are going to have off axial forces, the periodontium will start responding and it will start becoming widened. Similarly, the bone is going to be destroyed in this process and tooth will become mobile in the socket. The adaptive capacity of the periodontium to occlusal forces, it varies in every single individual and even in the same individual at different times and even at different sites. Like there is occlusal trauma to premolar on one side and same type of trauma on premolar on the other side, there will be not the similar type of destruction over there in both the premolars. It will be different depending upon the situation. And why it will be different? Because this is influenced by the magnitude of the force, direction of the force, duration of the force, how long the force is acting over there, and how frequently that force is being applied. Over the period of time, different authors and different authorities, they have defined the trauma from occlusion as, like in Carenza, when occlusal forces exceed the adaptive capacity of the tissues, tissue injury results. The resultant injury is termed as trauma from occlusion. According to Linde, a term used to describe pathological alterations or adaptive changes which develop in the periodontium as a result of undue force produced by the masticatory muscles. Well, Stillman, you must be knowing this name, Stillman, from your periodontology, the guy who is famous for identifying the clefts in lower anteriors, which we know as Stillman clefts, the gingival clefts over there. So Stillman clefts. According to him, a condition where injury results to the supporting structure of the teeth by the act of bringing the jaws into a closed position. World Health Organization rephrased it in 1978 as damage in the periodontium caused by stress on teeth produced directly or indirectly by teeth of the opposing jaw. American Academy of Periodontology in 1986, they defined it in the glossary of periodontal terms as an injury to the attachment apparatus as a result of excessive occlusal forces. So from all these definitions, few things are clear. First of all, the damage is to the periodontium and it is via teeth. The damage is coming from the teeth. And why it is there? Because of some undue forces or overload or excessive forces or even the directions of forces, undue forces, whatever the condition, the problem is occurring at the supporting structure. So this is trauma from occlusion. Factors that help increase the traumatic forces: magnitude, direction, and the duration. When magnitude of occlusal forces is increased, the periodontium responds with a widening of the periodontal ligament space. And also lamina dura, that is going to respond as well. Its density is going to increase. So when you see a condition where there will be widened periodontal ligament and the alveolar bone, or you can say lamina dura, is also thickened, it means the person is having some trauma from occlusion. Another thing which you will see, without any periodontal involvement, without any pulpal involvement, the furcation area is also going to have some radiolucency. These are all indicative of trauma from occlusion. The direction of the occlusal forces we have already discussed. The periodontal ligament fibers are arranged so that the occlusal forces are applied along the long axis of the tooth. Change in the direction of the occlusal forces lead to change in the orientation of the periodontal ligament fibers. And even the number of fibers in response to the trauma, it is also going to be increased. Duration and frequency of occlusal forces. Constant pressure on the bone is more injurious than the intermittent forces. People who are clenchers, they are continuously clenching their teeth. And if you will look at their periapical x-rays or even bite wing x-rays, you will see that clenchers, generally their teeth, they have widened periodontal ligament because a constant pressure is going to be applied on the teeth. Your teeth are not designed for that. If you look at the Possel's envelope of uh, occlusion, so what happens in that, I will just draw it roughly for you. It is something like this. From centric relation to centric occlusion, there is, like as I told you, in most of the people, there is always a shift. And then from the uh, protrusion to excessive protrusion, and then we have excessive opening, and then closure will be in 2. So over here in this area, from centric relation to centric occlusion, most of our cyclic movements of chewing, they occur over here. They are excessive opening and closing and excessive movements. Our teeth, they come in contact for a very brief period of time. From centric relation to centric occlusion, like when they come in initial contact from centric relation to centric occlusion, those people where centric relation and centric occlusion, they are at the same place without any shift, means there is no shift occurs laterally or anteroposteriorly, then we do not have even this line present. It will be just a single line, like single spot, and then the protrusion, excessive protrusion, and then the opening. Things like this will happen. This line is not going to be there. From here, it will be extreme opening and like closure and all that. So it will be like this. This line will be missing in those people. Teeth, they come in contact for a very brief period of time. Even at rest, we have centric relation, not centric occlusion or maximum intercuspation. So the more frequent the application of an intermittent force, the more injurious the force to the perio. Just a minute, let me change the pointer. I don't know why it is not letting me change. Yes. Okay. So how do we classify the trauma? Trauma is either acute or it is chronic trauma. We also classify it as primary trauma or secondary or combined. Like it is actually type of secondary and combined, they are almost similar, but how they are different in a very little manner, like very minute difference between the two. The major types are primary and secondary. Acute trauma from occlusion. It results from an abrupt occlusal impact, such as that produced by biting on some hard object. Maybe you are eating something like maybe a shawarma or something, and olive is not pitted. It has pit in it. It's like the hard central part is still in it, and it comes without unknowingly between your teeth, and then ouch, you get hurt. That is acute trauma from occlusion. Apart from that, person who got some restorative procedure done, like in recent past, they come back with pain in that restoration. There would be some high spot, hyperocclusion, maybe a new crown where there would be hyperocclusion or new bridge, and even the removable partial dentures, if they have some high spots, the effect will be on the abutment teeth. So that is like all these are the examples of acute trauma from occlusion. So it could be any reason or even habits, newly adapted habits, and they will also lead to acute trauma immediately. Well, what would be the clinical features? Pain in that tooth, sensitivity to percussion, and tooth will be mobile. Chronic trauma from occlusion. It is more common than the acute form, going on silently. Once we find out that, oh my God, this person teeth are being fractured or being worn out, the vertical is low, and all other problems they have started, including the TMJ problems. Then we realize, oh, this person is actually having chronic trauma from occlusion for a very long period of time. It most often develops from gradual changes in occlusion produced by tooth wear, drifting movement, extrusion of teeth, and combined with parafunctional habits like bruxism, clenching, so many things. Primary trauma from occlusion. If tooth is healthy, no periodontal involvement, no microorganisms present in the sulcus, everything is good, and some recent high filling, a faulty restoration, a new fixed prosthesis or a removable prosthesis is there, or maybe from some hard object in the food, it will lead to primary trauma from occlusion. The secondary trauma is in those cases where already a person is having some periodontal condition. A periodontitis is there. Now the bony support is basically all destroyed because of periodontitis. It is not that healthy. The microorganisms are there, some calculus deposits, plaque accumulation, everything is there. And the trauma, it has started. Or maybe person is having now a new filling or a new restoration. What is going to happen in that case? The progression of periodontitis, apart from other things, the progression of periodontal disease will be manifold. It will be progressing at a very high speed. So such type of condition is known as secondary trauma from occlusion. At times what happens, because of this periodontitis, teeth, they drift, they migrate. When they drift and they migrate, so they acquire a new position and some premature contacts they develop. So that will also cause the trauma from occlusion. And already there is destruction, microorganisms are there, periodontitis is there. The destruction will be at a very high pace. Clinical features of trauma from occlusion. First clinical appearance will be mobility, which will be progressive. Pain on chewing or percussion. Phreamitis is a special type of mobility. You will ask the person to bring the teeth together. Then you damp your finger, and then you are going to feel it on the labial side or on the buccal side, and you will feel that the tooth is mobile while the person is just, while the teeth are together, they are trying to jiggle their teeth. That is known as phreamitis, and phreamitis is a typical sign of trauma from occlusion. Then there will be some signs of occlusal prematurities, discrepancies, or even there will be wear facets in the presence of other clinical indicators of trauma from occlusion. Tooth would be migrated, chipped or fractured tooth, teeth, or even restorations. And definitely there will be sensitivity to the teeth from hot or cold, either liquids or even the food. Radiographically, the first sign will be widening of the periodontal ligament. Then the second sign will be thickening of the lamina dura. And later, even in the absence of periodontitis, there will be, like, if the trauma it is going to be there, it will be continued, then there will be angular or vertical bone loss, and also the radiolucency in the furcation area. What would be the treatment? What is our goal if we find out that there is trauma from occlusion? We need to bring the periodontium back to comfortable and healthy status. And how we can achieve that? Firstly, we will see the different types of, like, etiology. Remove the etiology. How we can do that? By occlusal adjustment, management of the parafunctional habits, or you can go for temporary, provisional, or long term stabilization of the mobile teeth with the help of some removable or fixed appliances. If teeth are having any, like, they have moved from one place to the other place, drifting has already occurred because of periodontitis or something like that, then you also seek the help of an orthodontist, and you will align the teeth. Or even occlusal reconstruction. At times we see that the tooth is broken or fractured, or the restoration is not good. So you can go for recusping, reshaping, by crowning, or by placing an occlusal overlay or inlay or onlay. So you have to do the occlusal reconstruction as well. At times, certain people, they will need even the full mouth rehabilitation. At times, what we see, that the tooth is like in such a position we cannot save it anymore. Either it is extruded so much, or it is tilted so much, or it is out of occlusion, then we have to sacrifice that tooth as well. So over here we are done with our today's lecture, and inshallah soon we will meet with some more interesting topics. You can always get back to us and let us know that what topics you want to discuss, and I would be more than happy to share whatever I know, whatever is my knowledge, to with all of you, because I believe in the fact that the more you share the knowledge, the more it is going to be increased. So thank you very much.
Thanks a lot, sir. It was a very great lecture. Inshallah, see you soon. Khuda Hafiz.
Allah Hafiz.